So welcome back to Endoscopy Essentials. We are in the middle of trying to understand the new endoscope generation of our main sponsor, Olympus. And welcome back, Ingolf Mesecke-von Rheinbaben. You have explained the improved imaging functions of the, let's say, conventional image, but you also offer an alternative conventional image, which is quite different, and it's called TXI. So please explain.
Yes, so TXI, texture and color enhancement. The idea of this function is to indeed increase the visibility of any kind of suspicious areas, but different from NBI, this should keep the color representation. You all know NBI changes the color setting. TXI is not really doing it. It keeps the impression of a white light image. How does it work? You take a normal white light image, and now we're talking again about computer algorithms working here. This is not optical. The image will be split into two. One element is the texture, and the other one is the brightness. And now you can, once that is done, you can adjust the texture and optimize it. The same you can do with the brightness. The need for this is technologically, if you change the texture on the full white light image, you would also have an influence on the brightness and vice versa. By this technical trick, you can actually optimize both without an influence. Afterwards, logically, you bring this together, we call it stacking, and then you get your image back with an optimized texture and an optimized brightness. Afterwards, you can still adjust the color a little bit to what you feel is the best color representation. And that's how you can use this TXI, hopefully, to enhance the visibility of lesions.
So again, different features are split, processed, and then put together. You were talking about adjustment or optimization. Is that a constant one-time thing, or is it adapted all the time depending on whatsoever brightness and distance?
It is a constant thing, so it's always done in the same way by the technical system, but it has been developed and evaluated with many of physicians to tell the technical side, the engineers, where the optimum really is, because as an engineer I would not be able to do that.
And you said you can modify it as a physician. Usually there is some warning if you give the physicians too many options, that they lose control or so, but what can we do? Can we make it brighter, or what kind of adaptation, maybe together with an Olympus engineer, should we do?
You can adjust the brightness, the color scheme. You can make it a little bit more pale or a little bit stronger colors, but you can also leave it in the default setting, and you don't even have to touch it at all.
Okay, I can tell you the images are pretty similar on that slide, but in reality it's a different picture. And there are fans and people who are hesitant, so it's very, very interesting, and we have to find out what the real benefits are. And again, I think we have to ask Professor Stefan Seewald from Zurich. Stefan, what's TXI and how do you use it? Okay, we have now seen the specific features of TXI, and the question again is, Stefan, how does it look like in clinical reality? What are the differences?
I think we have to distinguish a little bit where we are in the GI tract. So maybe let's start with the Barrett's, because this is very common. I think it is a useful tool to use, and we always have to detect Barrett's early cancer. That is a big issue. And here is an example. So I'm using white light, and this is now TXI. So yes, what we can nicely appreciate here, we have the enhanced color, we have the enhanced structure, enhanced brightness. But for sure we are also using NBI, and with NBI we can better visualize the vessels. The question is here now, do you detect there early cancer in this picture?
The left side, Stefan, is what? It's the new generation?
Left side is new generation, yes.
No TXI. And in
No
the
TXI.
middle we have TXI.
Middle is TXI.
But this seems sharper.
It seems sharper because I think, especially in the Barretts, I have the impression that you can better visualize the structure, and that makes it somehow sharper. And then you have also the advantage that the image is somehow brighter, you know. And this is
so it's more structured, and you
more structured,
perhaps
definitely.
can better recognize structural abnormalities.
Structural.
We don't know the clinical outcome, but we're just focusing on pictures and see the difference. And you know, with NBI, you have color differences as well. So it's kind of built from the left side, which is vague, to the middle, where you think there is something on the right side, and then to NBI, where it becomes clearer.
Yeah, I mean, from the clinical point of view, if you look for a lesion, you first look if you have an abnormal structure. So I think that's why TXI is very helpful to detect this abnormal structure. And then it is always the point that NBI we somehow use for better classification and because we especially focus on the vessels. I think you need both filters, definitely, but we have definitely more information than only with the regular white light.
So for clinical application, we have to find out what's the best sequence and whether the detection accuracy goes up, but it's interesting to see those pictures.
Definitely, yes, but I also have to admit that you have to look to watch carefully. I think here in these three images you don't see any early cancer, so I think using a cap is still mandatory, because here in this case we have an early cancer here in this area, and for sure in such a case we need then the zoom, NBI zoom, and here you may nicely appreciate this is here the lesion, and it's a high-grade dysplasia, and this patient needs endoscopic resection. But when you compare to the first image, it was not well visible, and I think in this is an example. The filters or the post-processing features helped somehow to assess the lesion, the Barretts, but the most important here is also using CAP and new technology.
Stefan, what's at 5 o'clock here?
At 5 o'clock, this is
at the margin of the picture.
This is inflammation.
How do you know?
How do I know? Because cancer always shows smaller cells, smaller glands, and here you may appreciate that we don't have really smaller glands. So these are very irregular, but here you see the nice difference that here you have smaller glands compared to this area. This is here inflammation. And then another interesting point is also you see the color difference here. This area looks more silver than the surrounding. And for sure you have more atypical vessels here compared to this area.
Okay, I out myself as an imaging skeptic, but you're going perhaps to convince me. So let's go on.
Okay. Yes, here again NBI zoom, and here you definitely notice
it's a structural area.
Yes, a structural area, and here also these corkscrew vessels, they are ending blindly, so there's no connection anymore between the capillaries, and this is definitely early cancer.
Do you dare to predict infiltration depth?
Here, this is a big issue. Here, I would say here are some avascular areas. So here you may expect already more than only high-grade dysplasia, but the final histology here in this case was only high-grade dysplasia.
So I see. So even you are skeptical that you can, from the superficial pattern, precisely predict what's going on in depth, right?
You're right. It is still very difficult and complicated, especially in the Barretts. I think in the squamous cell cancer, it is you can predict more precise, but in Barretts it's still complicated. Also, we have to admit in the Barretts sometimes you have here a lot of large glands, and the cancer is finally then somehow hidden in smaller areas where you don't have these large inflammatory larger glands. So Barrett's is still very, very complicated.
So the issue is inflammation all over the place, and then you have some malignant cells, but you can't precisely predict what is what.
Exactly. The mix-up with inflammation and early cancer is very complicated. So,
but
yes.
Definitely there's something wrong here, if you see that.
Yes, definitely, yes.
Whatever it is
But I
precisely,
have to,
yes.
but I have to admit, sometimes you would not detect this without using a cap at the endoscope.
Yes.
Yeah.
I'm also a big cap fan.
Yeah.
I'm an imaging skeptic, but I'm a big cap fan. Okay, let's go on.
Okay, so this is another example. So that also should show you the new features. So this is the new white light. I think you will notice it is very sharp. You have a good illumination. And also in this patient, we have a lesion. It's, I can tell you, it's at 2 o'clock. And yeah, the question is now, will these new features help us in the detection of such lesions? I think this example also shows you what you have mentioned before, that because we can better visualize structural abnormalities, TXI is very helpful to find out the area in the long Barrett's where something might be wrong. And then in the second step, we again used NDI, and here in this case we also have an early cancer here in this area at 3 o'clock. A problem is for sure also when the patient is referred to our center that biopsy was performed before, and then it is difficult because you have a scar, and then it is also more difficult to describe these early
On the
lesions.
other hand, in all fairness, we also have to say that methodologically we have a huge advantage. We get a case where we know there is something and we have to find it, whereas the poor colleague outside, he scopes hundreds and hundreds of patients and he has to detect the one
Exactly.
among, I don't know, 200, 500,
Yes.
Where is something wrong. So that's a totally different challenge, isn't it?
We always have to congratulate the referral gastroenterologist to find such small lesions in maybe 30 patients per day. This is really a challenge.
It is, and this opens, I wouldn't like to go in depth, but there's always the advice from reference centers, don't biopsy, just look. But if you don't have experience, good instruments, and you don't have the selection, it's better to take more biopsies than say there is nothing and I don't take biopsies.
Yes, I fully agree. It is also the point when you want to perform a resection, somehow you need to present this case in the tumor board, and then they also ask for the histology. So
Right.
a biopsy is necessary, and we are not perfect for sure, but in this case we have a little bit more difficult imaging with regard to the infiltration depth because there has been a biopsy before, but I think this has no consequence with regard to the treatment strategy.
At the end, we don't know what
Exactly.
the biopsy causes,
Yes.
etc. But, you know, from left to right, again, everybody appreciates there are changes and there's probably more clarity.
So this is now, here you see now this lesion. This is now, you can appreciate the whiteness of the scar. And also you may nicely appreciate this pathological capillaries, also corkscrew vessels which are blindly ending. There's no connection, there's no mucosal structure anymore. So I think this is also a nice example of a small early Barrett's cancer lesion.
No, absolutely. But honestly, the high-grade dysplasia looked worse before, right?
Exactly, yes.
Okay, very good.
So yes, this is another example how we should use the new features. I think you're very good in the current data. NBI was also always recommended for better detection of Barrett's early cancer lesions. But if you have a patient with a severe reflux esophagitis,
Image gets worse.
image gets worse. And what is very interesting with TXI, this bile reflux or acid reflux doesn't disturb you that much. So in case you have such a severe reflux esophagitis, I think TXI is quite helpful to use, again, in order to detect if there is somewhere something wrong.
I agree. Right side, nice picture, but you see nothing.
Yes, definitely. Another example here, also a patient with a very special Barrett's large glands. And here we have the same problem when we are using NBI. The bile reflux is really disturbing our image. And here with TXI, we have brighter and sharper image. I think my impression is that TXI is quite helpful in the endoscopic assessment of Barrett's esophagus.
One question I have to ask you, acetic acid staining?
Yes, I think we are used to using the filters, etc. And I think acetic acid is a little bit behind. So my referral gastroenterologists, they are using acetic acid, and I think there are several examples where it is really helpful. This is an example. This is a patient who underwent EMR of mucosal cancer, and then he was sent for radiofrequency ablation. So I have checked this patient before, and when we look here at this image, you may appreciate that here we can see some structural abnormalities, but I think you could also sell it as an inflammation. When we used the TXI, gets bigger, definitely bigger. We can visualize this better. And now, using NBI, you will notice that we have slightly beginning capillary abnormalities. So this is what we can get out of the filters and post-processing filters. But now I put vinegar, and you nicely appreciate that the structural abnormalities you can see quite better than with TXI or NBI. And now we have the possibility to combine the classical and the virtual chromoendoscopy, and I think this is very helpful because these structural abnormalities of combination of white light and vinegar we can enhance again now with TXI. And I think we can better delineate the lesion by using vinegar in combination with TXI. And now I'm additionally using indigo carmine, and again we have the best delineation of this lesion with this combination, and for sure now we can again use TXI, and I think this is the best image in this patient.
I haven't used it for a long time. I hated it.
I know.
But that's a convincing image.
Yes.
Ah. So that's the largest extent of all images. It gets larger and larger.
Yes.
Great. Stefan, you were mentioning squamous cell epithelium and lesions. Do you have examples for us as well?
Yeah, for sure. So this is a patient, and she got upper GI endoscopy for abdominal pain, and finally a lesion was found here about 3-4 centimeters, 70% of the circumference, and this is the regular white light. And now I can stop here quickly. In this,
I think what's very interesting here is, of course, there's a clear lesion, but I think people should train their eyes for the surrounding redness, because sometimes you have a red spot which is very flat, and you think that's, I don't know what that is, but that's very, very suspicious. This is how it starts, and you can train your eye at the margin of those lesions.
Exactly.
Because sometimes they're infiltrating underneath and it's high-grade dysplasia at the margin, but this is the abnormality, this is the difficult abnormality if it comes alone.
You're right. So the first what we see in the white light is that the lesion or the suspected area is a little bit more reddish, and then you should focus your eye on this area. But now we have the so-called better white light, the TXI, and here in this case you may appreciate that we can see this abnormality already better. And I think it's also very interesting, the more structural abnormalities you have of a lesion, the more visible this is with TXI. And here we have a lesion with different cancer infiltration depths. So here, this area, I will show you later the histopathology. This is still mucosal cancer, also here in this area, but here, this area, this is already submucosal cancer. And
because it's bulky?
It's more bulky, and now we are using NBI because you know this IPCL classification. I mean, it's not perfect, but I think it's not. It's quite good. So now I'm using NBI, and now we focus on the vessels. And here you may nicely appreciate that the most abnormal capillaries are here in this 1 centimeter area in the middle. And
you still do staining? Yes.
Yes, I still do staining because I want to show you which effects we also have in this combination. So this is Lugol staining. This effect we can enhance with TXI. And for Lugol staining, we use for the neutralization sodium thiosulfate. And now when we use this, you can nicely see that again the effects of the Lugol staining come better out with TXI. It is the so-called pink color sign, so Lugol and white light, and you have to wait 3, 4 to 5 minutes, and then the cancer lesion turns pink, like here. And you also have the metallic silver sign, where you have, when you're using now NBI, that the area is more silver than the surrounding area.
And this lesion looks more circumscribed, right? Which you assuming that it's submucosal infiltration?
Yes. So we discussed now, can we still go for endoscopic resection? So we had here from these classifications de-looped capillaries. We had some avascular areas, so somehow the lesion is between mucosa and submucosa, so we can still go for endoscopic resection. And here you see the histology. So here, this is in this area, it is a submucosal invasion of 100 micrometer and no lymphovascular invasion. So this is beyond the guidelines, but in many cases this is still acceptable that we can avoid surgery.
This is an entirely different topic, but
exactly.
I think the focus shifts a little bit. Before we were thinking, what are we allowed to do from an oncologic standpoint? So this is over the edge. Now we're trying to get on our zero resection because we are considering, and studies will be done in the future, to have an adjuvant treatment. So not necessarily surgery in high-risk lesions, but defining the risk patient, etc., and try to achieve an organ-preserving treatment.
Yeah. I think we experience somehow an organ-preserving revolution, and even our surgeons press us to resect the lesion first before surgery. We will get now the problem that we have a lot of non-curative R0 resections in the future, and the question is then what to do, because the resection is non-curative. But I think as long as possible, the lesion should be first resected,
yes,
like in this case.
That's kind of the new concept, and we have to find out oncologically what we will do. But that's a different topic,
yes.
But it shows that diagnostic requirements may change when the therapeutic concepts are changing.
Definitely,
right?
yes. So here I would like to show you another case of the colon, also very interesting. It is only a 1 centimeter large lesion, and here you may also appreciate the new features of X1 technology. So this is TXI. you appreciate the structural abnormalities, and now we are using NBI, and you nicely appreciate these smaller glands, these in the center, and these structural abnormalities, and also these vascular abnormalities. And the problem here in this case, it is only 1 centimeter from the anal verge. So in such a case, I like to do underwater endoscopy because you can get again more sharp images. And in such a case, we are also using crystal violet in order to look for the Kudo classification. Because Kudo classification you can only use if you have stained with crystal violet. So this is our regular approach in such borderline lesions where we have a huge discussion what to do. First we use all the new features, we do underwater endoscopy, and we also do this crystal violet staining.
Again, same issue. Therapeutic concepts are maybe changing here as well, but very, very nice pictures.
Yeah, but the point is a little bit, I think 5 years ago we would have discussed, can we still go for ESD, or do we have to send the patient to the surgeon? Nowadays we do intramuscular dissection, so I think imaging is quite important, because in such a case I would not primarily do an ESD, I would go for an intramuscular dissection endoscopically.
Very nice case.
I can also show you the histology. So in this case, we have an SM3 infiltration. We have a vascular invasion, but we had an R0 resection. I think we don't want to discuss now what to do, but what we can see is that even if we have a deep submucosal invasion, we still can achieve an R0 resection by endoscopy.
With expanded techniques.
Exactly. Another lesion in the colon, a young lady, 40 years old, and I think this looks very suspicious for cancer, exactly. So let's use now all the new technology we have available. So first TXI, and also this case shows very nicely that the abnormal structures are better visible. So I think the cancer is more on the right side of the lesion. The left side we still may have adenoma. And yes, here...
What do the lymphatic vessels mean on the side?
I think...
Nothing.
Not really. Yeah, nothing. I would also say nothing.
Mm-hmm.
So what I want to show here is we use also this indigo carmine, because with the indigo carmine you also have a better, you can better see the structures, especially in combination with TXI, and for sure now we are using NBI, and you nicely appreciate here this more silver center of the lesion. This is also suspicious here for cancer. So this is, the center is more silver than the surrounding. And you may nicely appreciate now with NBI these abnormal vessels. I think when we are using JNET, this is JNET type 3. And in such a case, we put the lesion underwater, and we are using this crystal violet, and then we may also look here for these pathological pits. This is Kudo type 5I and 5N, so this is a suspected submucosal cancer. And this is especially here in the right part of this lesion very nicely visible.
I think we also have to say this is an advanced lesion, and you do all this sophisticated imaging. It's probably helpful, but I think there's one effect people don't consider enough. You train your eye. So the smaller the lesions you get, if your brain saves all those images of structural abnormality, the hope is that you will become better in finding small suspicious lesions as well.
Yes, I think we should try to use the classifications we have. And I think this also helps us to get better, and also for sure to helps us to get the right therapeutic decision. I mean, this is a difficult decision what to do, but we definitely know that an EMR should not be performed in this case.